All right, so this is the first of 3 lectures on the anatomy of the female reproductive tract. In this first lecture here, we're going to be covering the anatomy of the ovaries and the fallopian tubes. So first, we're going to discuss the components of the female reproductive tract, just to give you an overview. So we'll start with the ovaries here, and then we move into the fallopian tubes here, which serve kind of as a conduit from the ovaries to the directly to the uterus, where pregnancy occurs, and then from the uterus, you have the vagina. The uterus, the female reproductive tract has several pelvic ligaments that help it stay suspended within the pelvis, and these are really just folds of connective tissue. The major one that we want to focus on for the uterus is the broad ligament, and it's a double layer of peritoneum, and it maintains the uterus position by attaching it to the pelvis, and then it also attaches to the other reproductive organs involved as well, so the ovaries and the fallopian tubes as well. So it helps keep this entire reproductive complex within a normal position in the pelvis. So it contains 3 parts. You have the mesometrium, which is the largest subsection, which is kind of this entire subsection here. And what it does is it surrounds the uterus, so it's here on both sides, so it's on this side and then on this as here as well, and it extends laterally to cover kind of the round ligament of the uterus and the external iliac vessels as well. So the round ligament will be coming out of here and then going down into the decumbent. Just a little diagram here to show you the other components of the broad ligament. So this is a sagittal view, so if we're looking at it from the side, so in this is an anterior view looking at the broad ligament. This is a sagittal view. So we already talked about the mesometrium, which is down here, which is that the majority of the broad ligament covering the uterus on both sides. So if you extend superiorly from the mesometrium, you have the mesosalpinx, which is what kind of projects to the fallopian tubes and helps suspend the fallopian tubes in their natural position. If you extend posteriorly, so this would be anterior, and this would be posterior. So if you extend posteriorly out to the ovaries, you have what's called the mesovarium. So this is a component as well of the broad ligament that extends out and covers the anterior surface here of the ovary. It also helps cover the neurovascular supply at the hilum of the ovary as well. So all 3 of these are just subsections of the one broad ligament. As well, the broad ligament encloses many structures, but as far as ligaments go, there's 3 key ligaments. So the round ligament of the uterus, which would come out here, and then travels within the broad ligament in here, and then it exits out and then goes through the inguinal canal, which we discussed in the abdomen. You have the ovarian ligament here, which connects the ovary to the uterus, and within the no neurovascular structures at all travel within the ovarian ligament. It's just strictly a connective tissue ligament to help fix the ovary in place. Then you also have the suspensory ligament of the ovary, which if we kind of draw out here, so this would be like the lateral wall of the pelvis, and then you have the suspensory ligament of the ovary traveling in like this, and it kind of enters the broad ligament like this at a oblique angle, and within this is traveling as the neurovascular, so the artery, the ovarian artery, the ovarian vein, and then nerves as well are all traveling within, and then lymphatics as well are all traveling within this ligament to the ovary. There's also 2 pelvic recesses that we want to talk about that are in relation to the female reproductive tract, because they both hold some clinical significance. These are formed by the peritoneum within the pelvis, and they're really kind of in the most inferior aspect of the peritoneum. So they're really these folds that kind of fold around organs. And the first one is the rectouterine pouch, which is in this area here. It's also referred to as the pouch of Douglas, and then you have the vesicouterine pouch as well, which kind of is this space in here. It's a much tighter space in here. This isn't the best diagram to show this, but it gives you an idea of where it is. It's vesico for bladder, uterine for uterus. Just to go into a little bit more detail about the rectouterine pouch or the pouch of Douglas. Again, it's formed by the peritoneum, so we'll draw it in here. So if you have peritoneum coming down in here like this, this region really right here is the pouch of Douglas. It's between the rectum and the uterus, so rectum here, uterus here, and it lies just posterior to the posterior fornix of the vagina. So that's this structure right here. So that's the posterior fornix of the vagina. And the reason that's significant, we'll talk about in subsequent slides, but this gives you kind of a direct access, if you would, to the pouch of Douglas. Because the reason why the pouch of Douglas is important is it's the lowest point in the female abdominal pelvic cavity, and thus if you have a collection of fluids within the abdomen or the pelvis, or a collection of infection, it tends to collect down in this area in the pouch of Douglas. And so the reason why that would be significant clinically is, one, this is where you would have all this extraneous material, either fluids or infection, collecting. And the other is you could sample it. So you could stick a needle up through the vagina into this posterior fornix and go just through the posterior fornix here and collect fluid lying here in the pouch of Douglas. The vesicular uterine pouch, just again, it's peritoneum here descending between the uterus and the bladder. So what are the ovaries? The ovaries they're paired female gonads. So you have one on either side. This diagram only shows you one side, but you have one on each side. And these are what are responsible for producing the oocytes, or the female gametes, analogous to the testes producing spermatozoa in the male. So you have oocytes, which are released during ovulation into the fallopian tubes where fertilization occurs. So you have the ovaries here, they release the oocyte here, and then they get collected into the fallopian tube here. They also function to produce sex steroid hormones and androgens in response to LH and FSH released by the pituitary. So if you have the pituitary up here, it releases FSH and LH, and then these go down and they stimulate the ovary, which then causes it to produce estrogen, and then, which is kind of the main female reproductive sex hormone, and then also androgens as well. The anterior surface of the ovary is anchored to the posterior surface of the broad ligament via the mesovarium. So back to the mesovarium via this. So back to this diagram here. So you have the anterior surface here of the ovary, and as you can see, it anchors to the posterior surface of the broad ligament via the mesovarium in this diagram. The ovaries themselves are not covered with peritoneum, but they're anchored in place by two key ligaments. And again, we talked about this earlier. You have the suspensory ligament of the ovary, which is very key because it's carrying, as we talked about, the neurovascular structures, and that helps kind of anchor the ovary to the lateral wall of the pelvis. This is a frequently tested topic on board exams because it's especially relevant during oophorectomies, which we'll talk about in subsequent slides, which is an operation to remove the ovary. And then you have the ovarian ligament, which we talked about, extends from the ovary to the fundus of the uterus here, and then from here you continue as the round ligament. So you have the ovarian ligament that anchors here, and then you have the round ligament that continues out here into the inguinal canal. Now, during ovulation, you have an oocyte, which is released out here by the ovary. That's during your kind of your LH surge. So if you look at your hormones, you have that LH surge here. If you were to graph over time, and then it's released into the peritoneal cavity. So here the oocyte's hanging out in the peritoneal cavity. And then what happens is you have these fimbriae, which are these like finger-like projections from the fallopian tubes, and they help kind of sweep the oocyte into the fallopian tube where fertilization occurs. So just kind of look into the structural components of the ovary. The surface here, out here, it's formed by a simple cuboidal epithelium. So look at these cube-shaped epithelial cells, and it's just one layer, simple cuboidal epithelium. It's also called the germinal epithelium. So you have the cortex here, which is kind of the outer portion within the parenchyma of the ovary, and this consists of kind of connective tissue, and then really the main part is the thousands of follicles in various stages of folliculogenesis, which serve to create the pre-ovulatory follicles that will enter into the menstrual cycle. So you can see in this diagram the different follicles here. They're all in different stages of folliculogenesis, and that's kind of carrying out the main reproductive function of the ovary. The medulla, which is kind of the central part here, this contains kind of just supporting stromal, so like connective tissue, neurovascular structures like the arterial supply, the venous drainage, the lymphatics, any kind of nervous innervation, and it directly enters at the hilum, which is right here, which then you'd have your mesovarium coming out here, connecting to the broad ligament posteriorly. The main blood supply to the ovaries is via the ovarian arteries, and these come directly off the abdominal aorta at the L2 vertebral level. And you can see that here in this diagram. So here's where each artery is coming off, and again, this is the L2 level. And you have the right ovarian artery going to the right ovary, and the left ovarian artery going to the left ovary. And the venous drainage is via the ovarian veins. And now there's something unique about these. They don't drain into the same systemic veins. So you have the left ovarian vein, which comes off the left ovary, and it drains actually into the left renal vein. It doesn't go directly into the IVC. And the reason for that is it's just the way the aorta and the IVC lie in relation to each other in the abdomen. It's just easier for the ovarian vein to go into the renal vein versus having to reach across the aorta just to get into the IVC. Now, on the right side, you have the right ovarian vein traveling up this way, and it can just easily go right into the IVC because the aorta is not in its way, so there's nothing blocking it. The sympathetic and parasympathetic nerve fibers are from the ovarian and pelvic plexuses. The ovarian plexus is a sympathetic plexus. The pelvic plexus is a parasympathetic plexus. The lymph drains into the para-aortic nodes. So if you have ovarian cancer and it's going to spread via lymphatics, the first nodes it's going to go to are the para-aortic nodes. And that's something that could come up on a test question. And again, all ovarian vessels and nerves travel via that suspensory ligament of the ovary that we've talked about. Some clinical applications for the ovaries. First, the oophorectomy. You've heard me mention this in previous slides. This is an operation that involves removal of the ovary. Now, the indications for this could be ovarian cysts, ovarian torsion, it could be ovarian cancer. Bottom line is you're taking the ovary out. And so what's involved in this ovary that's important is if you have that suspensory ligament of the ovary coming out here again, and you have those arteries traveling, the ovarian artery traveling in here, in the ovarian vein, what you want to do to prevent significant bleeding when you're taking an ovary out is you want to ligate this ligament, because that way you'll ligate the vessels, and then you can cleanly take out the ovary without significant bleeding. Now, what's important, and this is very high yield for board examinations, is you have the ureter, which travels just posterior to the suspensory ligament. So what a surgeon's going to want to do is to first isolate this ureter, which is traveling retroperitoneally, isolate this ureter so that they can cleanly ligate the suspensory ligament without damaging the ureter. Ovarian cysts. Now these are fluid-filled masses that kind of form on the surface of the ovary. So you have these, you can have a single one or you can have multiple one. They're usually benign. They can grow larger to cause bleeding and significant pain, and that's just through a mass effect. So if you have a little one, it's probably going to be asymptomatic. If you have a larger one that kind of grows like this, again, it can kind of press on different pelvic nerves or cause torsion on the ovary, which can lead to significant pain. And if these get big enough, they're going to need to come out. If they're small enough, they can be left alone, but if they're symptomatic, then surgery is considered to remove them. Now, ovarian torsion. This is usually when a cyst or it could be an ovarian tumor, if they get so big that the mass effect causes torsion of the ovary, which results in kind of twisting of this fallopian tube. So it's the mass effect here, kind of twisting the fallopian tube. And what this leads to is significant abdominal pain. These patients usually come in with very significant pain, and it needs to be treated with laparoscopy to unwind the twisted ovary, and then possibly you need to do oophorectomy, which is a surgery to kind of fix the ovary down so that it can't twist anymore. Ovarian tumors, we won't go into too much because these are a very complex pathological topic. If you want to know more, I suggest you consult your pathology textbook. But bottom line is these can develop from germ cells, they can develop from stromal cells, or they can develop from epithelial cells, and this is the majority. They have the big anatomical concept here is that they have the potential to metastasize to distant sites within the pelvis and the abdomen, including the bowel and the spleen and the gallbladder. So you can have ovarian cancer here, and it can end up, spreading up here to the gallbladder. It can end up spreading up here to the spleen. That's why ovarian cancer is so devastating, is that usually it's caught at later stages, and it really, a surgeon can open up a patient with ovarian cancer, and it can be all over the place. It can be in the omentum. You can have ovarian tumors in the omentum, those kind of fat pads within the abdomen. They really can spread anywhere. They can spread to the bowel, so they can spread to the rectum. They can even spread to the descending, ascending, or transverse colon. So really, gynecological surgeons that focus on gynecological oncology, they actually are skilled to do all these operations. They're skilled to take out gallbladders. They're skilled to take out spleen. They're skilled to take out bowel resections. So they're trained in really a significant amount of abdomen and pelvic surgeries. So now we're going to talk about the fallopian tubes. And they're a pair of muscular tubes that extend out laterally from the uterus, and they extend within the broad ligament, and then they open out here into the peritoneal cavity. And they function to carry the oocyte, which is released from the ovaries. So the oocyte is released, and then it's carried through the fallopian tube, where fertilization usually occurs, and then after fertilization, the zygote is then carried to the uterus, where it can be implanted to begin pregnancy. The fallopian tube can also help transport the sperm to the point of where the oocyte is located so that fertilization can occur. And it consists of 4 anatomical parts. These 4 parts, they're the fimbria, which are these finger-like projections right here. And these fimbria, really, they sweep the oocyte during ovulation into the fallopian tube. So you'll release the oocyte here, and then these fimbria kind of help sweep the oocyte out of the peritoneal cavity and into the fallopian tube. The inventibulum is the lateralmost portion, and it's the part that actually opens into the peritoneal cavity, and it's where the fimbria are attached. So to this section right here. So this is your infundibulum. Okay. Then you have the ampulla, which is, as you can see here, if you look at the diagram, it's kind of this larger diameter section right here. So this is your ampulla. And this portion is important because it's the section with the largest luminal diameter, and it's, as a result of that, it's the most common site for fertilization to occur. And that's a very high yield fact to know. That's something you could get asked on a class exam, on a board exam, on clinical rotations. And then the isthmus is the last part, which is the most medial part. So it's this part here that kind of extends and then opens up into the uterine cavity. So it's the medialmost section. The neurovascular supply, it's really via 2 arteries, just really the tubal branches of the uterine artery, which is from the anterior division of the internal iliac artery, and then also from the ovarian arteries. So you can see the ovarian artery traveling in here, and it gives off kind of these tubal branches that supply the fallopian tube. The venous drainage is via branches to the uterine and ovarian veins. The lymph drains to the iliac, sacral, and aortic lymph nodes. The sympathetic and parasympathetic innervation, it's provided by the ovarian and pelvic plexuses respectively. So ovarian sympathetic, and then pelvic plexus is the parasympathetic plexus supplying the fallopian tube. And then the sensory afferent travel through the T11, L1 spinal roots. So some clinical applications: salpingitis, inflammation of the fallopian tube, also known as pelvic inflammatory disease. Just again, if it's inflammation of the tubes. This is a very high yield topic. You'll see this in the clinic, very highly tested on board exams. What happens is the complication is what they like to ask about, and so it can lead to adhesions within the lumen. So if you look at kind of a cross section here of the fallopian tube, and the fallopian tube, it's kind of a simple columnar epithelium, and it has these kind of like projections like this. If you look at the cross section of it, it has these projections of mucosa or epithelium. So what can happen is you can have these like adhesions that form as a result of the inflammation, and what happens as a result of these adhesions is that it's either partially or completely obstructing the lumen. which increases the risk for fertility and then also ectopic pregnancy. So let's say the oocyte makes its way into the ampulla here, and let's say you have some inflammation here, some pelvic inflammatory disease, and you have an oocyte here. This can give you an ectopic pregnancy, which we'll talk about in a subsequent slide. But an ectopic pregnancy is basically a pregnancy outside of the uterus, and that causes significant problems. Now, the majority of pelvic inflammatory disease is caused by bacterial infections. It's usually one of two bacteria, Neisseria gonorrhea or Chlamydia trachomatis. Now, when you treat these patients, you treat them with antibiotics to cover both, because you don't necessarily know which one it is. So you give ceftriaxone for Neisseria and azithromycin for Chlamydia. Now, a common board question would be, let's say you have a patient come in with PID, and you give them ceftriaxone, and then on a subsequent follow-up visit, they have, they're infertile, they can't get pregnant, or they come into the ER with an ectopic pregnancy, and they'll ask you what happened. Well, the problem is the treating physician didn't cover for both. They didn't give ceftriaxone with azithromycin. So you give both antibiotics to cover both bacteria. An ectopic pregnancy, as we've been talking about, it's an implantation of a fertilized ovum at a site other than the uterus. That's the key to the definition. So anywhere outside. So it can be in the fallopian tube. It can even happen in the peritoneum. It's most often in the ampulla of the fallopian tubes, though. So again, makes sense where most pregnancies occur, or more most fertilization occurs. If it's an acute presentation, it's an emergency that needs to be treated with urgent surgery. Any young woman that comes in with lower abdominal pain, obviously you'd be suspecting appendicitis, but you should also always have ectopic pregnancy on the list. And in fact, you should do a beta HCG test before you would do any kind of abdominal CT imaging in case they're pregnant. Lastly, ligation of fallopian tubes, also kind of known as tying the tubes. It's a method of permanent contraception, so there's no going back, and really it just involves surgical ligation of the fallopian tubes, which then the idea is that you prevent passage of the oocyte from the fallopian tube to the uterus. And then lastly, a salpingectomy is a surgical procedure to remove either the whole fallopian tube or part of the fallopian tube, and it's used to treat ectopic pregnancy. So if you have an ectopic pregnancy in here and it presents acutely, you can do surgery and you can take out this section of the fallopian tube. It can be combined concurrently with an oophorectomy and or a hysterectomy for gynecological cancers. So if you have an ovarian cancer or a uterine cancer, usually they just take the whole thing out. It's called a hysterectomy with bilateral salpingectomy and oophorectomy. It's where they just, because the problem is these tumors anywhere in the reproductive tract, they can spread, and they can spread to other sections. So just to be safe, they usually just take the whole thing. And that concludes our discussion of the ovaries and the fallopian tubes.